A very warm welcome to this VIA webinar titled Improving Outcomes for Neonates and Infants Receiving Non-Invasive Ventilation. We are delighted to have you join us this evening or this afternoon or this morning. I am pleased to inform you that the full live webinar will be eligible for one contact hour of CRCE accreditation from the American Society of Respiratory Care, and please expect to receive an email in the coming days with a post-webinar survey. We are honoured to have Dr. Ramnarayan, known as Ram, from Imperial College London, and Amy Hunter from the North Thames Pediatric Network in the UK join us today as our speakers for this webinar. Following the presentations, we will have the opportunity for some Q&A. Please feel free to pop any questions that you have in the Q&A box at the bottom, and we will share these questions with our speakers at the end. Without further ado, I would like to hand over to Ram. Thank you.
Thank you very much. Thank you, Chloe. Thanks, Wire, for inviting me to do this talk. So my role over the next 20-25 minutes is to talk to you a little bit about work of breathing and in the context of non-invasive ventilation in neonates and infants. I work in Imperial College in London and at St. Mary's Hospital on the pediatric ICU. So I'm not a neonatologist, but I do look after babies from birth up to children who are aged up to 18, 19. I don't look after preterm babies, but I do look after ex-prem babies who've come back to the pediatric ICU, either with respiratory illnesses or as a part of graduating from the NICU. So we have cared for babies who are 1.5 kilos upwards, if they have problems that are more suitable to looking after pediatric ICU rather than on an NICU. A very quick disclosure statement. Obviously, I am delivering this talk today on behalf of Wire Medical. I also do some consultancy for Sanofi Pasteur, but I'm not going to go through any proprietary names, trademarks, or medical devices as part of this talk. So the talk is structured roughly along these lines. Understand what work of breathing means, how we clinically assess work of breathing in children, in babies and infants, and the importance of supporting the work of breathing and methods by which we can support work of breathing. So first of all, when we talk about work of breathing, we don't really think about it as work because we all breathe and we continuously breathe. And we don't think about it as anything that involves work, certainly nothing like this person who's carrying a heavy load. But inherently, there is work involved in breathing. And some of our metabolic rate is determined by our breathing. And the work really involved is taking air from the atmosphere into our lungs. And if you imagine that that box that the man who is sweating is carrying is full of air, the job of this work of breathing is to take that air and deliver it from the atmosphere into the lungs. And one of the key things to mention here is that work of breathing effectively therefore means it's the energy that's required to inflate the lungs and the chest wall by a specified volume. So that is the work that's involved in breathing. And as you can see, from the atmosphere down to the lungs to the alveoli, there are several areas, several roads or several paths that you have to negotiate to get through to the end. And that starts from the nasal passages into the oropharynx and the nasopharynx, down to the glottis, the subglottis, the trachea, the bronchi, the bronchioles, the terminal bronchioles, and then to the alveoli. And remembering that the lungs are not sitting on their own, they are encased within a chest wall with ribs, muscles in the chest wall. So the energy required to inflate the lung and the chest wall by a specified volume is the work of breathing. So when we break it down a bit further to assess what this means, essentially there is resistance to air getting from the top into the lungs, and that resistance primarily comes from the airways. And there are airways all the way from the top, as I said, nasopharyngeal passages, all the way down, trachea, bronchi, terminal bronchioles, all the way down to the alveoli. There are airways. Elastance is the other component of work of breathing, and that reflects effectively the work that's involved in blowing the lungs up. So roughly, if you imagine that the work of breathing is breathing into a balloon, but with a long tube attached to it, the tube is the airways and the balloon is the lungs, there is work involved in blowing the lungs up, and that's elastance. The lung obviously has to expand, and the chest wall also has to expand alongside it. And those are the two primary components of work of breathing. This is important because work of breathing may be affected by changes to the resistance and changes to the elastance, or the opposite of elastance is called compliance. And probably better to use the word compliance here, because most of us understand that compliance means how easy it is to blow the lungs up or the chest wall up with air. And that's the principle that we're looking at. What is important to say here is that the lung is inherently in a state of elastic recoil, much like a balloon. If you blow the balloon, it opens up. But as soon as you stop blowing, it goes back to its normal state and the air comes out. And the lungs are essentially like that. They're in a state of elastic recoil, and that's what we have to get through in order to inflate it. So stepping back to airway resistance, the principle of airway resistance is that you have to have at one end of the tube higher pressure, and at the other end of the tube lower pressure, and air then follows. Much like plumbing, for example, you have higher pressure at one end of the tube and lower pressure at the other end of the tube, and the water or the liquid just flows through the tube. But what is important to remember is that the flow through the tube, or airflow through the airway passages, are determined both by the length of this tube or the airways, as well as the diameter or the radius of the tube. And importantly, worth remembering that the radius of the tube, making changes to the radius of the tube, has a very exponential change in resistance. So even a small change in airway radius means that the resistance rises by fourfold rather than, say, for example, double. And what that means is that when airways are small, resistance rises really quickly. And so what are the diseases in which we commonly see increased airway resistance? We see diseases such as asthma or wheeze, babies, premature babies with chronic lung disease where they have airway obstruction or airway narrowing, bronchiolitis, which is a viral infection of the bronchioles, or anaphylaxis, where there is bronchoconstriction. All these diseases are associated with increased airway resistance because the airway passages become more narrow. We talked about lung elastance as the other part of work of breathing, and the opposite of elastance being compliance, so how compliant the lungs are. And essentially the principle here is that you inhale, take a deep breath, and the ribs move up and out in adults. The diaphragm, which is the muscle at the bottom and between the chest and the abdomen, goes down, and therefore the volume of the thoracic cavity increases. When the volume of the thoracic cavity increases, the pressure goes down, so it becomes negative, subatmospheric, below atmospheric pressure, and air then rushes in from the atmosphere into the lungs. And then when the pressure equilibrates, when it becomes effectively equal, then inspiration stops and exhalation takes over. So that's a passive recoil. You just have to stop breathing in and you automatically breathe out. The muscle relaxes, and then you go back to normal resting lung state. Now, we all know that when we finish exhalation, we don't empty the lungs completely of air. We have still some air left in the lungs, in the alveoli. And when we are breathing normally, that residual volume is the functional residual capacity of the lung. That's the usual amount of air that's left over in the lungs after we finish breathing out. Diseases where lung compliance is affected make it more difficult for patients to breathe and have increased work of breathing. So for example, respiratory distress syndrome, which is obviously typical for newborns, and pediatric acute respiratory distress, which is the equivalent of similar pathology in older children, pulmonary edema, or bronchiolitis with atelectasis, are all examples of decreased lung compliance. Pneumothorax is another example of decreased compliance because the lung is not able to expand how much ever air you try to put into it because it's being compressed from the outside. So it's important to also think about not just lung compliance, but also chest wall compliance. So for example, in an adult, when the air is going in from the trachea, you can see the chest wall moves outwards because the intercostal muscles are contracting and pulling, and the diaphragm goes down. So that net effect of that is the thoracic cavity is expanded, the air comes in, and then when you breathe out, the chest wall moves inwards, the diaphragm goes up, and all the air is then pushed out in expiration. The problem in babies, particularly premature babies and small babies, is that the ribs are not ossified, they are cartilaginous. So they're very soft, they're very compliant, and as soon as they take a deep breath, rather than the chest wall moving outwards, the chest wall moves inwards because the chest wall is not ossified and the cartilage is not able to have enough strength to effectively move outwards. The diaphragm is the primary muscle by which inspiration occurs in babies. So the diaphragm contracts, the diaphragm goes down, and the chest wall expands, the thoracic cavity expands, but the chest wall gets sucked in rather than taken out because it's not strong enough. And equally, when the diaphragm relaxes and in expiration, the chest wall, rather than compressing and getting the air out, moves outwards. So you can see here there are some key differences between adults and babies and children in terms of the chest wall compliance. And what happens over age, as I just explained, the chest wall compliance is increased in younger babies and children and is much less compliant in older patients such as adults, adolescents and adults. The chest wall compliance is also decreased when there is obesity, when there's scarring, for example, from burns or from other reasons to the chest, or if there are skeletal anomalies that cause changes to chest wall compliance. So we've just talked about what worker breathing is and what are the factors that influence worker breathing. So next we go on to talk about how to assess worker breathing. So normal physiology between adults and infants is that there is increased oxygen demand in babies. So infants need 5 to 7 mils per kilo per minute of oxygen for demand, and adults only need about 2 to 3 mils per kilo per minute. So they need to have more oxygen delivered to the tissues when they are infants, which is why infants breathe faster on average than an adult, which is why the respiratory rate of an infant is 40s and 50s and 60s, but the adult only breathes at about 10 and 15. The second thing to say is that airway resistance is maximal in adults at the nasal passages. So 60% of the airway resistance of the total airway resistance is from nasal passages in adults. But in infants, it's not the nasal passages. They only account for about 20% of airway resistance. It's the bronchi and the small airways that cause increased airway resistance. And therefore, the importance of bronchoconstriction in infants is much more pronounced and makes a big difference to worker breathing. We talked a little bit earlier about decreased compliance. The adults have ossified chest wall, ribs and sternum are bony, whereas the infant has a cartilaginous chest wall, so much softer, much more pliant and much more compliant. And that causes some of the problems with worker breathing that's more than expected. So just a quick table here to show you what the factors are that are different in infants and why they have increased worker breathing compared to, say, adults. I won't go into all of them, but we've talked about many of these factors already, but some of the things, as you can see here, the diaphragmatic muscle is immature and therefore it fatigues faster, which is important because you cannot expect an infant to keep breathing and have increased worker breathing for a long time because their diaphragm will fatigue much faster than an adult, for example. You can also see some differences in the respiratory rate. As you can see, babies breathe much faster, usually because their oxygen demand is high, and so therefore they have a limited ability to increase the rate any further and increase their tidal volume much further than they already are doing. Whereas in an adult who breathes at 10 to 15, you can breathe much faster if necessary, up to 30s and 35s, and increase your tidal volume, which is not easy for an infant. So what happens if there is increased work of breathing? As you can see here, the volume of breath is on this graph, and this shows the volume of breath during inspiration rises, reaches a peak, and then comes down. At the same time, the same line shows you that's the end of inspiration and that's the beginning of expiration. And what is important to see here is that inspiration occurs when there is negative pressure in the chest, in the lungs, and in the pleural space. So the way this obviously works is that the diaphragm contracts when you breathe in, it expands the thoracic cavity, the negative pressure in the pleural cavity then reaches much more negative values. The lung then expands because the pressure difference between the outside and the inside is greater. Air rushes in, and as the pressure then equilibrates, then expiration starts. And so that's graphically shown here. So more negative intrapleural pressure through diaphragmatic contraction and intercostal muscle action. And that is reflected in why babies demonstrate work of breathing through the clinical measures that we see. So for example, we see subcostal recession because they have diaphragmatic contraction. We see intercostal recession because they have intercostal muscles trying to generate more negative intrapleural pressure. And the challenge here is that when you have, say, for example, bronchiolitis or pneumonia or RDS, the need for you to increase your intrathoracic pressure to more negative levels, to make it more negative, is the reason why you work hard. And the compensatory mechanism of nasal flaring that we see with work of breathing in infants is to increase the airway diameter, because they are trying to compensate for the increased work of breathing by increasing the airway diameter. Because remember, resistance and elastance are the two parts that make up the reason for work of breathing. Expiratory braking, which is you stop your expiration before you fully finish it, is grunting. And that's the grunting mechanism is to generate some positive end expiratory pressure to keep your alveoli open in the face of increased work of breathing. And we all know that grunting is a poor sign and a late sign of respiratory distress and work of breathing. So tachypnea is obviously one of the most sensitive clinical signs of work of breathing. Subcostal recession, as we've seen here, you can see the diaphragm pulling, and you can see because the baby's rib cage is quite compliant and not fully bony and not ossified and cartilaginous, you see this subcostal recession, which is essentially the diaphragmatic muscle pulling on the bottom ribs. You can also see intercostal recession in babies, and you can see that here between the ribs, and that's the intercostal muscles trying to contract to try and open up the chest wall so that there is more negative intrathoracic pressure. Nasal flaring, we talked about, again, to increase airway diameter, and also accessory muscle use, so tracheal tugging, and so that's the use of sternocleidomastoids and other muscles in the neck to try and increase the work of breathing through that route. And obviously, we talked about grunting earlier. So finally, on my talk, I'll be talking about the importance of supporting the work of breathing. We talked earlier about fatigue of the diaphragm. So the type 1 fibers in the diaphragm, where the proportion of type 1 fibers increases with age. So when you're young, you don't have the ability to carry on breathing and have increased work of breathing indefinitely. It predisposes to muscle fatigue. Remember, the diaphragm is the main muscle in infants that makes you breathe. The intercostal muscles aren't really that active. The rapid respiratory rate makes it inefficient to breathe. You can't breathe much faster than the usual baselines, and there's obviously increased oxygen demand. Energy expenditure from breathing is obviously a big consideration. So work of breathing takes up more of the energy needs when you have work of breathing that is increased. So for example, in adults, In a resting state, worker breathing only accounts for about 5% of oxygen demand. But when you have lung problems, say, for example, a pneumonia or chronic lung disease or COPD, it's up to 50% of your worker breathing. 50% of your oxygen demand is your worker breathing. But in contrast to this, worker breathing is nearly 25% of oxygen demand in infants. So any increased worker breathing is going to be consuming more and more oxygen as a proportion. So growth can be affected if you're on long-term respiratory support and have worker breathing. So the energy that you need to grow is diverted towards breathing. There's also a significant interaction between cardiopulmonary interaction. So this is between the heart and the lungs, where if you have problems with the lungs and increased worker breathing, you might get cardiac problems, and vice versa. So the reverse, where if you have heart failure, you have respiratory problems. So the ways in which we support children, infants with worker breathing, high worker breathing, is through offering respiratory support. The most common ways we do that is to offer non-invasive respiratory support through nasal positive airway pressure. It's either continuous or biphasic. It could be constant flow positive airway pressure, or CPAP. In the constant flow, the flow is constant, but the pressure is adjusted by varying the expiratory resistance. And in variable flow CPAP, the flow is adjusted at the nares, and the pressure is therefore maintained at the airway. So these are two different ways of delivering CPAP: constant flow and variable flow. And devices that offer CPAP will fall generally into one of these two groups. And biphasic CPAP, or biphasic positive airway pressure rather, is not continuous, but two varying levels of pressure, one higher level for inspiration, one lower level for expiration, so IPAP and EPAP. There has been some published work looking at constant flow versus variable flow CPAP devices, and you can see this paper from a few years ago in Neonates showed that tidal volume generated was higher when variable flow CPAP was used, and that's compared to constant flow CPAP here. And you can see that the angle of insinuation here, which is the degree of thoraco-abdominal dysynchrony, so this is where you see paradoxical breathing, is much lower where you have variable flow CPAP compared to constant flow CPAP. So there's more evidence that variable flow CPAP delivery devices are more effective than constant flow. What about work of breathing, and what is the impact of CPAP on work of breathing? This is some experimental data from 2011 in babies with bronchiolitis. And you can see here that 4 different metrics or measures of work of breathing were assessed on patients who were breathing spontaneously. And this is the pressure in the esophagus, which effectively is pleural pressure. And you can see there are wild swings in the pleural pressure, so quite negative pressures to try and draw the air in because of the work of breathing. And once you apply external positive pressure through CPAP plus 7 centimeters here, much better profile with not such negative intrapleural pressures needed to be generated, which obviously then reduces the work of breathing. Pressure time product is another way of measuring work of breathing. And you can see here that at around 7 centimeters of water pressure, the work of breathing through the PTP is much lower here compared to other numbers on CPAP or even spontaneous breathing. And that can be similarly seen in other forms of non-invasive respiratory support, such as high flow, but not quite to the same degree. So I'll summarize there and wind up to say that work breathing depends on 2 components: airway resistance and and lung compliance and chest wall compliance. And so anything that affects airway compliance, airway resistance and compliance will have an impact on work breathing. And that clinical signs of work breathing include all the common things that we know of: nasal flaring, recessions, grunting, but hopefully there's a bit more clarity on why these things occur. And finally, the importance of decreasing the work of breathing for respiratory support for both acute health as well as long-term health. So for in the acute instance, you don't want babies to tire and stop breathing and become apneic, and you have to intervene early. And obviously for long-term health, in terms of growth, in terms of development, and in terms of cardiopulmonary interactions. I'll stop there. I'm very happy to take questions at the end of the session. Thank you.
Thank you so much, Ram, for that fantastic presentation. I would now like to hand over to Amy. Thank you so much.
Thanks, Chloe. Thank you, everyone. So today I'm going to be speaking about improving the outcomes for neonates and infants receiving non-invasive ventilation. So my name is Amy Hunter, and I am the lead educator for the North Thames Pediatric Operational Delivery Network. And my background is a pediatric critical care senior sister and also a pediatric retrieval nurse. So just for disclosure, I've been asked today to do this talk by Via Medical. I would like to start by addressing the following objectives for this short session. So the nursing care for neonates and infants receiving non-invasive ventilation. How as health professionals we can maintain and protect infants from skin integrity whilst on non-invasive ventilation, and the consequences that skin injuries can have when they occur. The impact noise can have in the NICU and PICU, and the importance of reducing noise to improve these outcomes. In my personal experience, 3 important things to remember when caring for a baby receiving non-invasive ventilation are to ensure the baby is as comfortable as possible and tolerating the therapy. So keeping the baby as calm as possible and involving family to ensure family-centered care. Babies receiving CPAP can be very unsettled at times, and the patients that require the most work to keep them calm and happy. A huge part in keeping them comfortable is ensuring you have fitted the generator and headgear properly so that their skin is taken care of and remains intact. Skin injury can have a huge impact on a baby's treatment and the ability to administer CPAP, so it is a high priority. So keeping the baby calm can also make a difference to their tolerance to the treatment. As we know, the NICU and PICU are loud and noisy places, so by reducing their noise can greatly aid in their ability to rest and continue to grow. Whilst infants are receiving CPAP, we as health professionals can promote family-centered care. Infants can have regular cuddles with their family. Not only will this keep the baby calm, but it will also give the family time to bond with their infant and help to reduce family anxiety. Family can also help with cares without the fear of knocking any equipment. So let's first discuss some nursing care considerations for looking after a baby when receiving non-invasive ventilation. Prior to commencing non-invasive ventilation, getting the infant into a position they find most comfortable or tolerate is vital. The most recommended positions are supine, side lying, or in the prone position. The infants will need 4 to 6 hourly regularly repositioning for pressure relief. Repositioning should be clustered with cares, including eye, nose, and mouth, and nappy care to promote rest and ensure recruitment of alveoli through prolonged PEEP. Comforting the infant to keep them calm and settled. So we can do this by a number of techniques: swaddling, comfort cuddles with family, analgesia prescribed, and non-nutritive sucking, such as sucking on the dummy, and the use of sucrose following local guidance. When first commencing non-invasive ventilation, most infants will be nil by mouth, so ensuring that they have intravenous fluids to keep them hydrated and the electrolytes that they require. Restarting feeds will be on a case-by-case decision from the medical team and their clinical condition. However, small amounts such as perhaps a ml then used with the dummy to be able to offer them some comfort. Further to these considerations, infants should be nursed in a safe environment with monitoring on, access to suction, oxygen, and resuscitation equipment. Safety checks should be adhered to, including ensuring they appropriately set alarms on the device that you're using. Humidification should be on and the circuit warm prior to connecting the baby. Humidification and warming of the inspiratory gases is a very important aspect of CPAP, or nasal biphasic positive airway pressure. In normal breathing infants, the flows are very low compared to the gas flows that occur when administering CPAP. High flow gases dry the mucosa, decrease the mucocapillary function, and increase airway resistance. It's ideal to deliver the gases at a temperature of 37 degrees with humidity. Neonatal and pediatric patients are at very high risk of pressure damage due to the vulnerability of their skin. In some circumstances, when an infant is critically unwell, maintaining their skin is not always a priority, and we can neglect this. The first stage of managing skin injuries is prevention through routine skin assessment on the skin physiology at the given gestational age and age of life. So routine skin assessment is an essential part of reducing the risk of acquired skin injuries during an admission to NICU or PICU. Research has found that nasal skin damage in a neonate or infant receiving CPAP is preventable. One of the most unpleasant and painful CPAP-related complications is the risk of nasal skin breakdown. It commonly occurs on areas under high pressure of nasal interface, mostly on the nasal bridge, but can take place at any area under pressure of the mask or prong, which are used to connect the ventilation system to the patient's nose. There are numerous patient-related risk factors which can accelerate the occurrence of nasal skin damage, but our review of the literature shows that its occurrence is often associated with inappropriate care in delivery of ventilation. The nasal skin of the premature neonate is very fragile, which makes it susceptible to breakdown if continuous pressure exerted on it by the nasal interface, and therefore needs regular examination of the pressure of the mask or prongs and positioning. Health professionals in the NICU and PICU, especially associated nurses, should minimize nasal breakdown to improper nasal prong or mask placement. When we're caring for these patients with CPAP prongs, providers should monitor for signs of nasal trauma, such as dryness, redness, bleeding, abrasion of the skin, and narrowing of the nasal passage. Selecting the right mask size, using a tolerable pressure for fixing the interface, proper fitting of CPAP prongs or mask, and avoiding over-tightening of the head strap are some important care modalities which are used to decrease the risk of interface-associated nasal skin breakdown. Having appropriate care plans and clear documentation of the assessment of the skin and pressure relief of the mask or prongs should be in the infant's observation chart. So let's discuss the generators and interfaces. Generators are the devices that connect the interface on the baby's face to the CPAP machine and provide the CPAP pressure. There are various different ones out there with different designs and shapes. Generally, CPAP systems contains three main parts. An interface, which includes a mask or prong that fits over the nose, a circuit or tube for continuous flow of inspired air, and a driving force or generator, which provides an appropriate positive pressure with desired fraction of inspired oxygen. The nasal prong or mask is secured upon the nostrils by a headdress that is worn on the crown of the head. So it's vitally important to ensure you have the right size of headgear or bonnet before commencing CPAP. Having one that's too small, too tight of fixation can lead to head molding and irritate the fragile skin of the baby. If it's too large, the headgear can slip, creating torque on the generator and subsequently on the baby's face, and lead to the mask or prong dislodging. So depending on if you're using a headgear or bonnet, ensure that the correct hat size is used, using a measuring tape to measure the nape of the neck and measure back to the center of the forehead. When you're measuring, do not use the head circumference, as it does not provide an accurate measurement. Benefits of using headgear is that the cranium is accessible for interventions without disrupting treatment, such as cranial ultrasounds for neonates. Being able to attach the head and headgear prior to attaching the generator. Ensuring that the ears are in a normal position under the fixation and flat against the head. Folded ears can lead to huge problems, especially if the baby is in position on the side for a number of hours until the next position change. Ensuring that the eyes can be clearly visible, And ensuring you have a stable, comfortable fixation for the baby is really important, as this will maintain the non-invasive therapy, protect the patient's skin, and enables parent-baby contact. So selecting the right size interface is equally as important for delivering the therapy. Incorrect size masks or prongs can lead to excessive leak, pressure areas on the baby's skin, nasal injury, and worst of all, disruption of the treatment due to skin injury. So ensuring the correct size is selected, measure using the provided measuring guide. If the correct size is selected, the side straps do not need to be tight at all, and they're kept off the cheeks. The looser they can be, the better for the infant. Alternating between the prong and mask every 4 to 6 hours for pressure area care and protection of the skin integrity, but ensure the skin is being inspected frequently during this time. Again, ensuring that you document when you alternate between the two. The nasal prongs are one form of interface. It's important that the plastic is not touching the septum, which is a high-risk area for skin breakdown and injury. You need to be able to visualize the septum and nose at all times, so it is important that the generator allows a clear view of the septum. The nasal mask is a good alternative to the prongs when providing pressure relief. Some masks often migrate into the baby's eyes, which can lead to big problems. So it is important that the mask is shaped to provide eye relief. It is also important to regularly be able to inspect the baby's septum and nose, as sometimes you may not be able to remove a mask for up to 4 hours. This way, you can continuously monitor your patient's skin integrity. Like with the nasal prongs, the cheek straps do not need to be too tight and can sit off the baby's cheeks. In some cases, there can be a leak around the mask that may affect the pressure you're aiming to deliver. Ensuring you have the correct fitting headgear and interface are very important factors for maintaining your baby's skin integrity and reducing complications. So as briefly discussed earlier, babies receiving CPAP can be positioned in a number of ways, and we aim to reposition them 4 to 6 hourly and have them out for skin-to-skin contact and cuddles with parents. Cuddles with parents is an important part of family-centered care. Having babies on CPAP makes it really easy for parents to have cuddles with their baby and take part in care. It's important to remember that when repositioning a baby, to ensure you check their skin, eyes, and ears. Often with customer cares, it is the aim to have a hands-off approach with these infants. So when you're handing them for position changes and cares, ensuring that the skin is inspected. So nasal skin damage in a neonate and infant receiving CPAP is preventable, but what happens when skin injury does occur? As we can see in this image, here are 3 stages of nasal trauma. In image 1, we have stage 1 pressure sore, a non-blanching erythema. In stage 2, we have free superficial erosion. And in stage 3, we have necrosis of full thickness skin. All skin injuries must be reported via local trust incident systems and local policies followed. It's important to take pictures of the skin injuries with permission from the family for the infant's records, so it is easy for health professionals to see further deterioration or improvement. Nasal trauma is a frequent complication of CPAP, especially in preterm infants. This often arises due to the prolonged use of the device. Skin breakdown leading to nasal trauma is a serious complication of CPAP delivery, as a severe nasal skin breakdown could be a satisfactory reason to discontinue the use of CPAP, which could lead to the infant requiring mechanical ventilation if they still need ventilatory support. Mechanical ventilation does not come without complication. Infants receiving mechanical ventilation are at high risk for developing complications such as increased hemodynamic instability, increased airway resistance, acute and chronic airway trauma, increased ventilator-associated infections, and reduced clearance of secretions. Also having sedation drugs which may impact their neurodevelopment. If mechanical ventilation is avoidable by the use of non-invasive ventilation, it is therefore vitally important to maintain the infant's skin integrity to avoid it. The next area I'd like to discuss is noise in the NICU and PICU. It is well documented that environmental noise is associated with negative developmental outcomes for infants treated in the neonatal intensive care and the pediatric intensive care. Research has shown that environmental noise is associated with negative developmental outcomes for infants treated in the neonatal intensive care and the pediatric intensive care. Infants are exposed to invasive, loud and continuous noise and sleep disruption during critical periods in their neurodevelopment, which can be avoided. The WHO recommends the NICU should not exceed 45 decibels in the daytime and 35 decibels at night. However, numerous studies show that the preterm infants are exposed to consistent high noise levels ranging from 50 to 90 decibels, with peaks as high as 120 decibels. To put this in perspective, a running lawnmower is approximately 96 decibels. Several studies show that noise in a NICU may be responsible for hypoxic episodes or behavioural changes. The noise for patients receiving CPAP is produced by the alarms from the devices and patient monitors, the flow of medical gas, communication amongst health professionals and visitors, and during activities of nursing and medical care. There is no denying that infants receiving CPAP are subjected to an increase in noise. Some generators are much louder than others. A study by Karam et al. In 2008 investigated the sound induced by CPAP devices and looked at 3 older generation CPAP generators, including the Arabella, Medijet, and Infant Flow. The study showed that noise generated by CPAP devices are correlated to airflow, but not to generator pressure. It also showed that CPAP induced noise exposure more than 90 decibels could be measured for 2/3 of their infants. Loud noise in the NICU has been found to lead to physiological instability, reflected in fluctuations in blood pressure, tachycardia, apnea, and oxygen desaturations. By lowering the sound levels that reach the neonate, the resulting stress can be diminished, thereby promoting growth and reducing adverse neonatal outcomes. So in summary, ensuring infants are comfortable, calm, and promoting family-centered care will improve infants' compliance with non-invasive ventilation. Infants are at high risk of developing pressure sores. However, professionals can prevent this through regular skin assessment and pressure relief between the mask and nasal prongs. In addition to this, it's crucial that the correct size bonnet or headgear is chosen for the infant to avoid skin irritation and prevent the mask and prongs from slipping. Skin breakdown leading to nasal trauma is a serious complication of CPAP delivery and could lead to intubation and mechanical ventilation. And lastly, by reducing noise for infants in NICU or PICU, it's been found to improve outcomes and promote growth. Thank you so much. I'm now happy to take some questions.
Thank you so much, Amy, for that presentation. We do have a couple of questions in the chat that I can share with you both. The first question is for you, Ram. If a baby continues to have work of breathing once they are established on nasal CPAP, what else could be done to support the work of breathing?
That's a good question. I think we would obviously do all the basic things such as positioning the baby and suctioning to make sure that there's no obstructed nasal passages, etc. But really, if CPAP isn't working, then you could escalate to bilevel pressure. So that's bilevel positive airway pressure. So you'd have a higher inspiratory pressure and an expiratory pressure. And that usually is sufficient to get most babies through the work of breathing. But if obviously that fails and there's either hypoxic or hypercarbic respiratory failure, they'll need to be invasively ventilated. And that's obviously something we try and avoid as far as possible.
Thank you. Amy, I have a question for you. Are there any advantages to using either the headgear or the bonnet?
I would say from my own experience that the headgear, the infants definitely find more comfortable. It's less restrictive. You're not having to pull it over the head and down to the head. As I said in my presentation, you're still able to do cares and any interventions, so such as scanning the head, and they just tend to seem to tolerate the headgear more.
I had another question about your opinion on feeding during non-invasive ventilation and at what stage it should be initiated.
Sorry, is that for me, Chloe?
I can hand it to both of you, yeah.
Again, yeah, from my experience, it really depends on the baby's clinical condition. So if you're seeing that they are improving and that they are stable, and you're discussing with the medical team that they're happy to start feeds, I think it's on a case-by-case basis, and also your trust policy with feeding. I don't know if Ram's got anything to add to that.
Yeah, I wasn't sure whether the question was about oral feeding or nasogastric feeding. I think nasogastric feeding should be relatively safe for babies who are in mild or moderate respiratory distress. I think definitely not for severe babies with severe respiratory distress. As Amy says, I think it is dependent on how sick the child is at the time. But oral feeding, I think definitely we would avoid during the period of respiratory distress. Probably mild respiratory distress might be okay, but I think anything that needs more than that, particularly if they're on CPAP for respiratory support, we would not be orally feeding them.
Great, thank you so much. Ram, I have another question for you about your experience with the different types of NIV modes, such as NCPAP and JoyPAP, and when would you use one over the other?
Yeah, I think that the normal starting point usually would be CPAP, because that's effectively continuous positive airway pressure. It doesn't do any inspiratory augmentation of pressure. So all you're doing is to help to decrease the amount of work needed to generate a negative intrapleural pressure throughout the respiratory cycle. But what you can then do, obviously, is to escalate to bilevel ventilation. So in our practice, we would usually escalate to bilevel ventilation if CPAP is failing. I think the commonest problems, as Amy's highlighted really well, is interface. If you get a good interface that has minimal leak, then you can do CPAP and BiPAP really effectively. But if you have device interfaces that are not suitable or leaking or not comfortable, then it's very difficult to deliver non-invasive ventilation modalities.
Great, thank you. I have another question about any advice for dealing with gastric distension with non-invasive ventilation. I can hand that over to Amy.
Yeah, so we would always advise that, especially when first starting the baby on CPAP, to have a nasal gastric tube in and to have that on free drainage. Again, you could also aspirate the air from the stomach. Sometimes you can get several syringes full of air, and hopefully that will help to decompress, and then leave it on free drainage.
Great, thank you. I have another question for Amy. When putting a baby on nasal CPAP, how many people should normally be around for the procedure?
Again, so most trusts might have their own policy on this, and certainly there might be checklists, so check within your place of work. But I would say that as long as there is yourself and a nurse and a doctor around, and I also just always let the nurse in charge know, certainly if a baby is deteriorating, just making sure that the appropriate people are aware. But as I said, I think every sort of trust might have a different policy.
Thank you. I had another question. One of the attendees has stated that they don't start switching between the nasal prongs and the mask until the 24-hour mark. Do you always switch between every 4 to 6 hours, or what is your personal experience with that?
My personal experience is that we do start changing for 4 to 6 hourly, just so that you can try to avoid these pressure skin issues from early onset. Again, as we spoke about, it does depend on the clinical picture of the baby. So if they do have severe respiratory distress, and changing those interfaces does make the baby deteriorate, I would just say that just discuss them on a case-by-case basis.
Thank you. Ram, I have another question. What non-invasive pressures would you use at maximum before intubating a baby?
I think that's a difficult one, because it's there is no absolute maximum that you would state. I think that CPAP, if you're on CPAP, clearly there's an escalation pathway towards BiPAP or bilevel pressure. I think there is no hard and fast rule, but I would say that if you've given a trial of BiPAP for a couple of hours at least, and if there's no response, then you should be thinking about escalating to invasive ventilation. I think some of the limiting factors for CPAP as well as for bilevel ventilation for these babies will be comfort when you turn up the pressures. So in reality, you probably can't really, give them very, very high, bilevel pressures. Probably no more than 12, 13, would be easily tolerated for these babies. So there's no absolute number, but I think it really depends on patient comfort and patient response to the pressure. There's no point going up from 10 to 12 to 14 if there's no response. I think if there's no response, you have to stop and evaluate the situation and ventilate them if that's what's needed.
Thank you. And I have another question. When would you choose high flow nasal oxygen therapy over nasal CPAP?
I think this is obviously dependent a lot on context and also the disease process. So I'm not obviously a neonatologist, and I know there are lots of randomized controlled trials comparing first-line high-flow nasal therapy compared to CPAP. But in pediatric setting, a PICU setting, I was the lead for a trial that recently reported in the JAMA, and we found that effectively there was no major difference between high-flow and nasal oxygen therapy and CPAP as first line, but we did see that there were failures or clinical failures with high-flow nasal therapy that could be rescued by CPAP. So I think the summary of that is that you can't get rid of one, you can't get rid of both or just have one. I think you have to have both modalities in your unit so that when you try one, if it doesn't work, then you can switch to the other and you can rescue a lot of babies by just switching.
Thank you so much. Amy, I have a question do you have any experience with additional barriers to prevent any skin damage, such as something that additional you would put on the baby's face?
No, I don't. I believe where I work, tissue viability specialists don't actually recommend anything. If obviously skin injuries do occur, we then refer them to tissue viability and discuss the appropriate barriers and treatment then. I know especially when infants are in incubators and they're heated, that we have to be really careful about what we're putting on the skin, not to cause any other burns as such. But I don't work in a neonatal intensive care unit, so I can't speak for exactly what they do in the neonatal intensive care, so they may do something slightly different, but in my experience, we don't put anything on there to prevent it.
Thank you. I have another question. What if pneumothorax occurs whilst using nasal CPAP? And I will hand that one to Ram.
I suppose one question is how common is pneumothorax on nasal CPAP? And the trial experience is that it's very uncommon. So even in babies with bronchiolitis or with other respiratory conditions, in the first ABC trial, which I was talking about earlier, there were only 1 or 2 incidences of pneumothorax in 600 patients. So I think we're looking at a very small risk, even on CPAP. I suppose the question about what do you do then? I think the question, obviously you have to drain the pneumothorax to make things better, because with positive pressure, that pneumothorax will get worse and will get bigger. Inevitably, it will not be easy to then manage the child and will end up having to escalate to invasive ventilation. So the chest has to be drained. I think the question is whether you could continue CPAP if they had a chest drain in situ, and potentially you could, as long as there was an active chest drain that was working. But in general terms, people would advise to try and come off non-invasive respiratory support, positive support, pressure support as quickly as you can, so that you don't make things worse. But obviously, if you don't drain the pneumothorax and don't deal with it, you may have to intubate them, and that makes things even worse because you'll be then generating positive airway pressure through invasive ventilation.
Thank you. Time for probably one more question. Ram, what is the nasal CPAP pressure that you usually select to start with, and why do you select that pressure?
So we would usually start on a pressure of 6 to 8, depending on where it's possible to achieve that pressure, because obviously, as you know, sometimes babies don't tolerate much higher CPAP pressures because the flow rates might be quite high for them. So somewhere between 6 and 8. If you see that physiological study that I presented from bronchiolitis earlier, they identified 7 as the sort of most optimal pressure for starting CPAP, or where the most effect was. I think somewhere between 6 and 8, starting at 6, trying to escalate it a little bit to 7 as far as possible to keep the baby comfortable, and to go up to 8. You could go up to 10 if there's non-response on the PEEP, but I think by this point you'd be limited by comfort of the CPAP. If the interface is very comfortable, you may be able to get good pressure of 10, but I think if your interface isn't so well suited to the patient anatomy, then you might struggle to get the pressure anywhere more than 8. And so that might become a limiting factor. So somewhere between 6 and 8, probably start at 6 and inch your way up to 8.
Fantastic. Thank you so much. I think that's all the time we have today. I want to say thank you so much to our wonderful speakers, Ram and Amy, for your great presentations. And thank you so much to all those who have registered and tuned in for the live webinar today, and for all of the questions that we've received as well. Wishing you a good evening and a good night. Thank you very much.
Thank you.
Thank you. Bye. Good night.